All right, good morning. We're going to be talking about chapters 14 and 15, but one of the first things I'm going to start off with is talking about postpartum hemorrhage. So I just want to share some information from ACOG on current guidelines on postpartum hemorrhage, because some of the things that we're going to be talking about, such as measuring the perineal pad. Is the perineal pad soaked completely in 15 minutes? Did they soak it completely in 30 minutes, 1 hour? All right, so that's just one piece to the puzzle. So just to kind of give you a little background, postpartum hemorrhage causes about 11% of maternal deaths in the US, and it's also the leading cause of death that occurs on the day of birth. About 54 to 93% of maternal deaths are due to obstetric hemorrhage, and they are preventable. So you really want to be astute in your assessment skills, really looking at the whole entire picture, looking at the amount of blood loss, looking at the vital signs, looking at the factors that could cause postpartum hemorrhage. What was mom's maternal history, pregnancy history, labor history, previous deliveries, trauma. So we're looking at everything. What was her baseline H&H? What is her postpartum H&H? So we're looking at all of that into perspective. As we talk about some of the assessment findings in postpartum hemorrhage, we are going to talk about blood loss. A lot of evidence base is now going to quantitative instead of visual. We're going to focus on the visual, but I just want to let you know that if this is an area of specialty that you're going to get into, they're going to take this much further. And the most recent data is to look at quantitative, weighing it. And there's a lot of different ways that they will go about it. And there's a lot of postpartum bundles that you may hear of as you go further in. We're not going to get into that extent. We're going to talk about it, what you need to be a competent entry level RN. So there is a lot more to it, and I just wanted to share that with you before we got started. Okay, so let me share my screen with you. And let's get started on chapters 14 and 15. Okay, so the objectives for today is we're going to talk about primary causes of postpartum hemorrhage and related interventions. We're going to talk about complications and their related interventions postpartumly, and psychological complications. Then we're going to go into chapter 15. We're going to talk about the neonatal assessment, nursing care for the neonates during the first week, and common therapeutic surgical procedures for the neonates. So we end our neonatal care postpartumly, and that's where we end it, and then it transitions over into pediatrics. Okay, so chapter 14 starts off, we're going to talk about postpartum hemorrhage. So the definition is blood loss greater than 500 milliliters vaginally or 1,000 milliliters cesarean. Take a two-part approach to this. So think about first aid. So if you see somebody bleeding, you're not going to be like, well, why are they bleeding? What caused that to happen? Did they fall from a tree? Did they hit their head? No, we're going to treat it, correct? The same thing. The first thing you want to do is treat that hemorrhage. Then when we get that blood under control, excuse me, then we're going to identify what caused that. Because if we don't identify what caused that, then we're going to go back to step one and we're going to have bleeding again, right? So keep that in mind. So the primary causes of postpartum hemorrhage is what I call the 4 T's. I'm sure you've heard of that before, the 4 T's, when you were doing your readings. So you have tone, tissue, trauma, and thrombin disorders. All right. So tone, tissue, and thrombin disorders. So what do you think of when you think of tone? I have here uterine atony. So think of some causes of uterine atony. A precipitous labor, a rapid labor, fibroids. I think a lot of times people don't think about fibroids. And some signs and symptoms would be a very boggy uterus, passing some clots. So that would be your tone. Then when we go to tissue, I have here retained placental fragments. And sometimes people will think, well, how would we not catch retained placental fragments? When a woman delivers, we're assessing the we're assessing the placenta, right? We're looking at it. We're looking at the maternal side. We're looking at the fetal side. We're making sure it's all intact. Think about someone who had an unknown abortion. And when we say abortion, I'm not talking about the medical procedure where they do not want their child or their fetus anymore, and they go and they have that baby aborted. I'm talking about the woman who's maybe less than a month pregnant or 2 months pregnant, doesn't even know she's pregnant and has and aborts the baby, or fetal demise when they don't know that the baby is has passed in the uterus. And you're like, well, how would you not know that? They go for your ultrasounds and they get checked. How many people don't go to prenatal care? So think about that. Um, trauma. Trauma could be your lacerations, and it can also be a hematoma. So remember, we talked about this in postpartum assessment. We talked about your lacerations. We talked about your hematoma. Your lacerations could be just a little steady trickling of unclotted bright red blood. Your hematoma can be several different areas. It could be vulvar, it could be vaginal, it could be cervical, it could be retroperitoneal. Sometimes it's difficult to see. You may see they may have sudden onset of perineal pressure and pain, but they could have a firm fundus. Okay, so we're knowing if they've got a firm fundus. Don't know why my throat's bothering me today. Um, then they can have they you're like, okay, their fundus is firm. They're not hemorrhaging. There's nothing going on. Think about trauma. Think about that. So they can have a bulging area just under the skin, difficulty voiding. And in this situation, medical intervention is needed. You need to call the provider. They will most likely need to go to the OR to have that hematoma repaired. And then your last T is thrombin disorders. Some medical factors that can cause it would be preeclampsia, stillbirth. And again, we can see that stillbirth also in the tissue as well. In the thrombin disorder, you may see idiopathic bleeding, where they're bleeding from the IV sites, petechiae, bleeding gums, abnormal clotting values, different things like that. So risk factors, I highlighted some biggies. Uterine atony, a very boggy uterus that does not firm up upon fundal massage. Ineffective uterine contractions. So either they had a very prolonged labor or they had a very quick, less than 3 hour precipitous labor. Other risk factors could be administration of magnesium, previous C-section. Again, there's your lacerations or hematomas, retained placental fragments. What would you expect to see? Again, keep in mind, I want you to have a thorough assessment. So really hone in on those assessment skills when you graduate. I don't care if you are ER, if you go to the oncology, if you go to ICU, if you go long-term care, if you decide to work in an outpatient clinic and be a dialysis nurse. Assessment is key. Having good assessment skills is key. Listening to your patient is key. Okay. So you want to look for that change in locate. Remember, we talked about that in postpartum assessment. So where they are going from rubra to changing in their my brain's like it's like 6 o'clock in the morning right now for me. But anyway, they kind of reverse and they're going from very light or scant bleeding to heavy bleeding. Okay. They have a boggy uterus that does not firm up from massage. blood clots larger than a quarter. And remember, I talked about that evidence-based practice. If you are going into this practice, if you are going into the obstetrical field, you're going to get into this in a lot more detail when you go in for your orientation, where they're going to be talking about quantitative is better than visual. They're going to have a lot of bundles. Perineal padding, soaking the in within 15 minutes or less, is considered excessive versus saturated within an hour. So just a little bit more descriptive there than what we talked about in postpartum assessment. A constant oozing or frank bright red blood. Vital signs, very tachycardic and low blood pressure. Looking at these signs of shock. So think back to shock, think back to first aid, think back to fundamentals, tachycardia, hypotension, pale, cool, clammy skin, and a very decreased to little to no urine output. So some management protocols. You want to fundal, perform fundal massage. Again, this fundus is not firming up to fundal massage. Some key things is making sure that the woman has a large enough IV access for blood products. So you want to make sure that she has at least a 16 or 18 gauge. Increasing fluids, maybe running fluids wide open. You might hear that, running fluids wide open. That comes with experience. A lot of times we're like, oh my gosh, call the provider and just open those fluids. If they're experiencing signs of shock, the time it takes to pick up the phone and call, open those fluids, but you will learn that as you go. Inserting an indwelling urinary catheter. If they have oxytocin, increase the rate of oxytocin. You don't need to get into the specifics of the doses, but I put this there for your reference. Other medications will be methergine, that is administered IM. You may repeat that. Hermabate, IM, may be repeated every 15 minutes, max dose of 8. Misoprostol, you going to give that either prorectal or PO. Make sure you have a type and cross. You want to also, I'm not going into this. This is a fundamental skill that you learn, but please, hint, 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 revisit blood administration and OR stat. If no interventions are effective, OR stat. We need to intervene, find out what's causing this, and stop this. DIC is disseminated intravascular coagulation. And basically the woman is, they're breaking down the clots faster than they can form them. And this is where you see this idiopathic bleeding, this bleeding of unknown cause. You'll see it in the IV sites, nosebleeds, petechiae. They're brushing their teeth and their gums are bleeding. Risk factors: abruptio placenta, fetal demise in the utero or missed abortion, like they talked about, preeclampsia, which leads to HELP. Remember, HELP syndrome is a complication of preeclampsia, right? So HELP syndrome and hemorrhage. Assessment findings, I think I already talked about most of these, that spontaneous bleeding, bleeding from all different sites, and then your tachycardia, tachypnea, hypotension, and those signs of shock. Managing, you want to get, stat labs, identify what's causing it, blood transfusions, fresh frozen plasma, FFP, fresh frozen plasma, platelet transfusions, oxygen, and your cryoprecipitate. All right, we're going to talk about care of the woman with a postpartum psychiatric disorder. So I'm going to play this video.
I didn't know much about postpartum depression prior to giving birth. It just wasn't something that was discussed. I definitely didn't want anyone to know, and I don't think I even talked to my family much about it. I think my mother only found out recently that I had even gone through, real postpartum. It was just not something we talked about. And even once I told my mom, she's like, I had something like that when I had you, but I don't remember. We've never talked about it before until recently.
Postpartum depression is a mood disorder that can affect women shortly before or soon after childbirth. Any woman, regardless of her race, age, social, economic, or educational background, can be impacted by this condition.
Women with postpartum depression present with a persistent change in mood that not only is associated with some disturbance in their life, but also a persistent uh, mood that will extend beyond 2 or 3 days and will, go beyond 2 weeks. The range is between 7 and 14% of live births. So in this country, that works out to be approximately 500,000 women per year that are at risk for developing postpartum depression.
There's an overwhelming sense of anxiety as well as sadness. And there's also the tendency to isolate, and the chance for suicide is much greater in postpartum depression.
In the first 3 weeks or so, I started noticing that I just felt just completely overwhelmed and stressed. And, it definitely was not going according to plan. I wasn't sleeping. Not that you sleep that much when you have babies anyway, but I was a mess. I was crying. I could not seem to shake that sort of overwhelming feeling that I had. I think I always worried about something happening to my babies or me. I think it was constantly in my head then, like I couldn't relax. I was just very wound up and, constantly checking on them. I was probably overdoing it in hindsight.
80% of women experience the baby blues. Transient anxiety, worry about, am I a good enough mom? Am I going to be able to do this? Am I going to be able to resume my normal activities? Those symptoms go away within the first few weeks of delivering a baby. Postpartum depression may seem like it starts out that way, but the ruminations, the obsessions, checking locks sometimes, going to the crib and making sure the baby is safe all the time, not being able to sleep, feeling disconnected from her baby or her husband or her family, becomes very problematic. She's unable to function. And those symptoms become daily and intrusive and are present within a month of delivering a baby.
In rare instances, a woman may develop postpartum psychosis, a severe condition occurring in 1 in 1,000 births. Women suffering from postpartum psychosis require immediate treatment by a healthcare professional.
Postpartum psychosis is very acute. It's very dangerous, obviously, because the mother loses the ability to be rational during that time. So in postpartum psychosis, you will get a distortion of reality that is so severe that could actually impair your ability to tell what's real and what's not. Postpartum depression, you continue to have a sense of reality and you continue to realize what's happening around you, but there is, you are impaired because of the sadness, because of the anxiety, but not necessarily by thoughts of psychosis and, delusions and hallucinations that women with postpartum psychosis will experience.
We had a home that had, at that time, it had like a landing upstairs, and I was sitting there and I was in a recliner nursing the babies one night, and it must have been like midnight, 1 o'clock in the morning. And I remember thinking, if we just all of us just fell over here right there, it was one of those things but then I kept nursing and I just sort of went on about my night or whatever. But I think that was one of those things I was like, okay, I'm really sort of flipping out here. My husband and I definitely talked about sort of it was time to do something to try to help me. And he was sort of like, go get some drugs if you need it. He's like, whatever you need, get it or whatever. and then heard about this program at NIH, which appealed to me. I learned about the NIH treatment study via the internet and research that we were doing.
Postpartum depression can be treated by psychotherapy. It can be treated by medication. Individual therapy or group therapy can be very helpful to a woman with postpartum depression. It's important for women to seek out help from a healthcare professional because that healthcare professional is usually aware of other resources that they can use, and then that individual will be more prepared to either intervene immediately or with a medication or to recommend other approaches to treatment.
I would like other moms to know that it's okay, it's normal if you do have it, it's treatable, and that to be active and to seek help and, not just sort of sit back and think that you can heal yourself over time and that sort of thing. Because I do feel like if I had not sought treatment, it's something that would have sort of festered over time and become more difficult to manage. If we talk about our experiences, if we're open about our experiences, then that sort of, takes this mask off where other women feel comfortable knowing that this is okay. Other women have gone through this and they're okay on the other end. But we need to engage in that conversation and continue that.
All right, so that described a woman that was going through postpartum depression. And we're going to talk about the different types. You have what we call the baby blues, postpartum depression, and the doctor on that video alluded to postpartum psychosis. So keep those three terms in mind. Some risk factors: rapid change of hormones. Think about that major shift of hormones, right? And non-breastfeeding mom, it's gonna change more quickly because they're eventually not going to be producing milk because they're bottle feeding. Not that I'm saying that a bottle fed a woman who's bottle feeding is going to be at higher risk for postpartum depression versus a woman who is breastfeeding, because that is not the truth. But it's just that major shift, that rapid decline in the estrogen and progesterone. The physical postpartum pain. If someone had a C-section, someone has severe hemorrhoids, somebody has a severe laceration, episiotomy, there's afterbirth, afterbirth pains, right? Socioeconomic factors, financial, where she's living. Are they living from paycheck to paycheck, barely making it, living with others because they don't currently have a home, all those types of things, decreased support system. I think of deployed personnel and people in the military who are moved to the other ends of the world, maybe even in other countries, in Japan or Australia, over in Hawaii, families in Pennsylvania, New Jersey, New York. So they're alone in this whole thing, and their spouses deployed, their spouses working, anxiety, unplanned or unwanted pregnancies, previous depressive disorders, low self-esteem, and history of intimate partner violence. So again, they talked about, in that video, they talked about postpartum depression. So there's three types of postpartum psychiatric disorders. The first and the mildest is postpartum blues. The second one lasts a little bit longer, is postpartum depression. And the last one, which is rare but is a medical emergency, is postpartum psychosis. And again, we talked about the risk factors. I want to share another story, and this is going to take you on the other end of postpartum psychosis. And this is just a little video blurb. Some of the students who were in the day group clinical may have had this as part of their clinical day, but not everyone had it. So let me play. This is just a snippet. This isn't the long video.
Lately, it's been hard to think about the future, but thinking about
Bear
the
with me at
future
the
is
ad.
human nature. At Edward Jones, our 19,000 financial advisors create personalized investment strategies to help you get back to your future. Edward Jones.
15 years ago, the nation was shocked to hear about this case. Rusty Yates returned home from work to a nightmare. His 5 children had been drowned in the bathtub by their own mother, his wife, Andrea Yates. Well, NBC's Janet Shamlian sat down with one of the few people who remains in contact with Andrea Yates as she lives out her days in a mental hospital.
It was a crime that horrified the nation in June of 2001, 15 years ago. Andrea Yates drowning her 5 children in the bathtub of her Houston area home. She then called 911 to report what she'd done.
You need an ambulance? No, I need a police officer. You have sent an ambulance.
Noah, John, Paul, Luke, and baby Mary, 7 years to just 6 months old. Her husband, Rusty, was working at the time. He returned to a scene of sheer terror.
Cops were crying. There was a lot of emotion there. They were the guys that had gone to that house and had to recover the bodies. This morning, police found...
Phil Archer of NBC station KPRC was the first reporter on the scene.
They brought Andrea out, and her clothes were still wet, and her hair was still wet from the bathtub. And they brought her out, and she looked like a zombie. There was a sort of wildness in her eyes.
Even with a long and documented history of mental illness, including suicide attempts, she was charged and convicted of capital murder. But the verdict was later overturned, and in a subsequent trial, she was found not guilty by reason of insanity. She testified she believed her children's deaths would save their souls. Andrea Yates was committed to a Texas mental hospital where she remains today, now 52 years old.
You talk to Andrea on a weekly basis?
I'd say probably about every 7 or 8 days.
How is she doing?
She is, I think, doing remarkably well. She has excellent care.
George Parnham was and still is Andrea's attorney.
There's not a day that goes by where she doesn't care for, talk about, is happy about her children's lives before June the 20th, and grieves for her children.
Parnham says she spends her days making crafts, which are sold anonymously to benefit charity. And according to People magazine, she also spends time watching videos of her children.
The hospital where she is, there are no razor wires, there's no bars, there's no armed guards, no fences.
For the most part, it's a life of solitude. She never leaves the hospital and has few visitors. And while the case comes up for review yearly, Andrea has never sought to be released. Rusty Yates divorced Andrea 3 years after the incident. He later remarried and had another child, a son who's now 8. According to recent court documents, his second wife filed for divorce last year. In a 2015 interview with Oprah Winfrey, he spoke about his grieving and where his acceptance is now.
For some reason, when I think about them today, I think of them as being, teenagers.
Because he would be 20.
Or young adults.
Your oldest son would be 20 now.
It's really easy to get caught up in how they suffered or the fact that they're gone. And what I tried to do was say, look, I'm not going to let these events steal, that joy, the joy that we had for those 7 years.
I can name a worse situation than this, maybe with the exception of Sandy Hook. The added element here, of course, is that the children were killed by the one person that should have guaranteed their safety.
5 beautiful lives lost. 15 years later, a tragedy that still resonates. For today, Janet Shamley and NBC News.
One of the other facts about the story of Andrea Yates, and you can look this up, is Andrea was a registered nurse as well. This should not have happened. This is a story of a woman with severe postpartum depression that led to postpartum psychosis that should have been caught, that should have been intervened, that someone should have noticed this happening. A lot of would have, could have, should haves in this case. Very, 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 very sad situation.
15 years ago, the nation was shocked to hear about this.
All right. So postpartum blues. Postpartum blues is also known as adjustment reaction. Baby blues, you've probably heard that. It occurs up to 75% of women. It's mild. It begins about 3 to 5 days after, and you see this more in first time moms. Again, it's that rapid change in the hormones, challenges of being a new mom, tired, trying to adjust to this new role, and just feeling overwhelmed, tired, and not able to cope, and just crying and kind of, oh, I'm not a good mom. Postpartum depression, on the other hand, oh, and postpartum blues does not last very long. Postpartum depression, the prevalence is less, about 28%, and many of the symptoms are indistinguishable from postpartum psychosis. So there's that fine line, and that's where Andrea stood. They knew that she had postpartum depression, but nobody was seeing that postpartum psychosis. Frequent crying, insomnia, appetite change, difficulty concentrating, making decisions, feeling worthless, obsessive thoughts of being inadequate. The difference between, and this is really key and important, and I'll talk about it again, the difference between the postpartum depression and postpartum psychosis is thoughts of harming themselves or their baby. In the first video, you heard the woman describe she was on the upper part of her house. The balcony overlooked the living room. She was in the rocking chair and she was nursing the babies. And for a moment, she thought we could just all go over this balcony. And then like something like, whoa, wait a minute. What the heck is the matter? That's wrong thinking. And she continued to breastfeed and, continue to go on. In postpartum psychosis, they would try to follow through on that thought. Okay. Or they'd have thoughts of delusions. So postpartum depression, the greatest risk occurs within the first 4 weeks. It's recognized in the follow-up appointments, or even now the pediatrician offices are also assessing, because remember, they're not going to the postpartum visit until about 6 weeks. So if we're waiting 6 weeks and this occurs within the first 4 weeks, we're not identifying it. So they're following up in the pediatrician's office because the baby is having that first appointment usually within a week or less, depending if they had, a jaundice. In the Edinburgh postnatal depression, you're seeing a score greater than 12. And one of the important things is you want to ask, is she considering harming the child? This is one of those cases where don't pussyfoot around. I hate to say it like that, but don't be like, oh, I don't want to make her feel bad or hurt her feelings. It's kind of like in psych, you flat out ask, do you want to hurt yourself? Do you have plans to hurt yourself? In postpartum depression, going to psychosis, wondering whether it's depression or psychosis, do you have plans to hurt your baby? Flat out ask. Here is the postpartum depression scale, and I believe I gave you a link to that. Postpartum psychosis is extremely rare. It's a medical emergency, and immediate intervention is needed. It increases the risk of suicide and infanticide. Symptoms: psychotic delusions, visual, auditory, tactile hallucinations. In Andrea Yates' situation, she was told that that was the way to save the babies. They saved their chance of going, because she had voices telling them. Agitation, confusion, irrational thinking, delusions. Higher incidence with women who have substance abuse, current or past, and she may believe that the newborn is evil or not allowed to live. Nursing care is really monitoring those interactions between mom and baby. And we talked about that in our postpartum assessment, remember? Monitoring mom's behavior, encouraging her to communicate, validate, address personal conflicts, reinforce compliance with medications. If she was on medications, continue to take those medications. Make sure that she's working with her OBGYN, the pediatrician, if she's breastfeeding. There are medications that they can still take while breastfeeding. Obviously, there's medications they can't take while breastfeeding, right? Oh, sorry about the typo there. But ask the client if she has any thoughts of self-harm, suicide, harming her infant, and provide for the safety of the infant and child. Treatment depends on what's going on. Talk therapy all the way down to heavy duty medications. If she is going to be putting on lithium, breastfeeding is contraindicated. All right, now we're going to talk about chapter 15, psychological behavioral responses of the neonate. So we're going to talk about the changes that are occurring throughout all the systems. All right, so let's start with the respiratory system. So major changes are occurring from the time the baby is intrauterine to extrauterine. So as the baby is going through the birth canal, those contractions, those squeezing movements of the contractions on the baby are starting to push out the fluid, and the baby's going to be transitioning from intrauterine breathing or not breathing, so to speak, to extrauterine life. So the lungs are going to go from fluid filled to air filled as the baby's going through the birth canal. And at the bottom here, the changes are initiated by the compression of the thorax, which forces the amniotic fluid from the lungs. Some of the things you want to watch for when the baby is born is signs of fetal respiratory distress. And we're going to talk a lot more about that in other lectures. So cyanotic, blue, blue baby, abnormal respiratory pattern. The baby may have periods of apnea and tachypnea. Now, at times, these newborn babies breathing may be irregular, but they're regular, if that makes any sense. So you have to look at, again, the whole picture. I say that all the time because I think sometimes students get hung up on these are absolutes, and there's no absolutes. There's no absolutes in nursing, okay? Retractions of the chest wall, grunting, flaring of the nostrils, and very hypotonic, very floppy. Circulatory system is going to change from a fetal intrauterine to a fetal extrauterine. So the three structures that are going to undergo changes is the ductus venosus, the foramen ovale, and the ductus arteriosus. I'm not going to expect you to be able to describe the pathophysiology that is occurring, as these changes are occurring, but keep that pathophysiology in the back of your mind. But you're not going to be tested on that per se, but you need to understand that, if that makes sense. All right, I'm going to play a little video. This doctor does a nice job of explaining, and it's actually a video that she prepared to go over with the parents so that they understand.
So a question that I often get asked, even by fathers after a baby is born, is how the baby has gone from breathing the amniotic fluid of pregnancy to breathing room air, and how that process occurs. It's a very complicated process that initially involves blood vessels in a baby when the baby is in utero that we don't have as adults. But the simpler part of the process comes in the actual labor process. So when a baby is inside a mother's womb, there are extra blood vessels that keep the baby from needing lungs the way that we need lungs to process oxygen. So in the womb, the baby actually doesn't use its lungs almost at all. And so they're full of fluid. That fluid keeps pressure on the blood vessels of the baby's lungs so that they don't open and they aren't needed. When the baby is going through labor, the natural compressive forces on the baby in the pelvis and with each contraction actually push that fluid out of the lungs with every contraction. And over time, what happens is as there's less and less fluid, the blood vessels in the lungs open gradually because there's less pressure on them. As that happens, they start to recognize more and more oxygen from the fetal blood supply, and they get even bigger. Over the entire labor process, as those vessels become larger and larger and start retaining more oxygen, one of the extra blood vessels that babies have starts to close. And that's one of the blood vessels that keeps the blood from going to the lungs while the baby is inside of the mother's womb. So as that blood vessel closes and there's less pressure on those vessels in the lungs, the air starts to go preferentially to the lungs instead of just the circulation that the baby has already had. When the baby is finally born and the fetal head is delivered, the baby starts to take those breaths by response to the lack of oxygen that it's experiencing. And those initial breaths bring even more air into these blood vessels in the lungs that are opening and allow those blood vessels to become as wide open as possible. Once those vessels are open and that other blood vessel has closed, the baby will breathe exclusively through its lungs. Sometimes what parents notice is that a baby is coughing or spitting after delivery or has a difficult time transitioning to breathing. And that's often because the baby hasn't squeezed all of the fluid that was in its lungs when it was in utero out to breathe air. And that can cause babies to have what we call transient tachypnea of the newborn, which is retained fluid in the lungs, which leads to difficulty breathing, sometimes taking shallow, short breaths instead of good, deep breaths, and sometimes difficulty sleeping. So some of those babies will need to have extra care or extra suctioning to get some of that fluid out. You'll also notice that the nurses in the delivery room really want to make your baby scream. And that's because that screaming and crying helps bring even more oxygen into those developing lungs and clear out the rest of that fluid.
All right. The next system we're going to talk about is the thermoregulation system. And I want to tell you, if you can take anything away from this slide and understanding body temperature, is babies don't have a shivering mechanism. Babies have a very difficult time warming themselves up. They depend on what's known as brown fat or adipose tissue that is stored in certain areas of their body, for example, in their scapula, that is going to help warm up the baby. So it is so key to keeping this baby's body temperature warm. And there's so many factors that can decrease the baby's body temperature. So just keep that in mind. Hypothermia leads to hypoglycemia and respiratory distress syndrome. So those three, hypothermia, hypoglycemia, and respiratory depression syndrome, RDS, are interrelated. And we're going to talk about that. Okay, so the baby goes from this nice, comfy intrauterine life where mom is regulating baby's body temperature and it's just the perfect temperature for baby. And they come into this cold outside world, this extrauterine life. So babies are instinctively born with less subcutaneous fat than their adult counterparts. Their blood vessels are closer to the skin, and you'll definitely see that in your preemies. They will have a flexed posture, and that is to decrease the surface area exposed, thereby reducing the heat loss. Smaller infants have a higher need for temperatures. Go away. I don't know what happened there. Sorry about that. Sorry about that. My computer needs an update, and it's very adamant about that update that it needs. Anyway, so you're going to see that these smaller infants have a higher need for temperatures, for higher temperatures. So really watch for these preemie babies. They are now delaying the bath. So it used to be that the baby's first bath was pretty much right after the baby was born, and then they're delaying that. And several reasons. They found that there's really not a lot of evidence that it's any better to bathe the baby right after delivery versus delaying it for a little while and let baby bond with mom and start the breastfeeding process. And also babies experience cold stress during bathing. So when you do go to give the baby their bath, you want the room warmed, you have all your supplies ready. And you want to have all your dry, warm towels and everything ready immediately to give to wrap the baby. This is that brown adipose tissue I was talking about because babies, again, do not have any shivering mechanism. So these are sensors that will perceive the drop in the temperature and then will stimulate the sympathetic nervous system is basically the pathophysiology behind what is going on. The brown fat appears about 26 to 30 weeks gestation to about 2 to 5 weeks after birth. So think about these preemies. They do not have this. Remember, we talked about, well, just to kind of go back to this last slide here, smaller infant need for higher temperatures because they lack this adipose, this brown fat. You're going to see, again, I told you, you're going to see it at the scapula area. You'll also see it in the around the adrenal glands, the neck, the thorax. Factors that are affecting thermoregulation: decreased subcutaneous fat, decreased brown adipose tissue, large body surface area. So your very large babies, you think, wait, it's only your small babies. But in your large babies, you have a larger body surface area to maintain temperature. And then loss of body heat. And now we're going back to fundamentals. Think about when you're learning how to take vital signs, temperature. When you were learning about temperature, you learned about evaporation, conduction, convection, and radiation. So if you want, pause this recording, because this is what I would do in class. Pause this recording and write down those 4 things: evaporation, conduction, convection, and radiation. And jot down in your notes that you're taking as you're listening to my lecture and you're taking notes, jot down what you think they are. So this is just a blurred version. Your textbook has a really nice picture in chapter 15 of the 4 mechanisms of heat loss. But what we have is, we have letter A is conduction. Letter B is convection. Letter C is evaporation, and D is radiation. So what did you guys have for these? So let's talk about the first one, conduction. So conduction is the transfer of heat to a cooler surface by direct skin contact, such as cold hands of the caregiver or cold equipment. So look at that. Let's look at graph A or picture A. Conduction, transfer of heat to a cooler surface. So the baby is on the scale. The scale is cold, right? It's metal, it's cold. It could, so that would count as your cold equipment. Now, how could we prevent loss of heat by conduction by putting a baby on the scale? Good. So hopefully you said that you put a baby blanket, some kind of a pad or some kind of barrier to go in between that cold surface and the baby. Now, of course, if you're using that to weigh the baby, you need to account for and subtract the weight of that blanket. I hope that you would know that. All right, the next one, letter B. Letter B you see is convection. And convection is loss of heat from the neonate's warm body surface to cooler air currents, such as air conditioners or oxygen masks. Okay, so air conditioners we would see when they were home. Oxygen masks you would see in the NICU. So they're losing their heat due to cooler air currents. So convection is your cooler air currents, such as an air conditioner or oxygen mask. So in that picture, it looks like actually a fan, which is also an air conditioner, so to speak, right? Letter C is by evaporation. So you see the baby is laying on, I don't know, table for an examination. They do have a cloth or barrier in between the baby and the table. So evaporation, the loss of heat, is occurring when the water on the neonate is converted to vapors. And you'll see that during bathing or directly after birth. So they're losing their heat because the water is converting to vapors. And as you see in evaporation, it's exactly what's happening. It's evaporating into the air. And then the last one, letter D, is radiation. Transfer of heat from the neonate to a cooler object that is not in direct contact with the neonate, such as the cold walls of the isolette or cold equipment near the neonate. Now, don't get radiation confused with conduction. Remember, conduction is they are directly on that cold equipment. In radiation, they're near. All right. So just to keep those in mind. Care of the newborn with cold stress. So we need to keep the baby warm. We need to keep the baby warm, right? And this is what I talked about. Excessive loss is going to result in compensatory mechanisms. The body's going to compensate for that. How? It's going to increase respiration. So try to increase the body temperature. Try to create heat. It's also going to burn more calories. Hint, hint, hint. Burn more calories to use those fat stores. So when they're burning more calories, they're increasing their metabolic rate. So if what they are taking in and what they are putting out is not equal, then that baby's blood sugar is going to start tanking. This increase in respirations, having a low blood sugar, having a low body temperature is going to lead to RDS, respiratory distress syndrome. Your preterms, your small for gestational are at increased risk. We will talk about the post-term or the large baby as well, but your biggest risk is your preterms and your small for gestational, but we see it in the very large or post-term as well. So the babies have this non-shivering thermogenesis, which is utilizing that brown fat, but it's going to burn calories. And when it burns calories, the breathing is going to increase, or it's going to lead to hypoxemia. The baby's not getting enough oxygen. It can also impair and cause intracranial hemorrhage and hypoglycemia. I want you to know, for testing purposes, for testing NCLEX purposes, they use the 40 milligrams per deciliter as your standard for hypoglycemia for the neonate. You may see it a little bit different in a NICU at Lehigh Valley or Muhlenberg or Pocono, or in different literature, but currently that is what they are considering. If it changes, I would let you know, but that is the current parameter. So basically, cold stress can be fatal. So you're like, okay, the baby's cold. It can be fatal. Okay, just keep that in mind. So signs of cold stress, the body temperature is dropping. There's a lot of discrepancies on temperature. 97.7 degrees. Some will say 97.5. So, at or about. Okay. Cool skin, very lethargic, floppy, hypotonic, very pale, and they're going to have a fast breathing rate. They're going to have this breathing called grunting breathing. Their blood sugar will be dropping. They're going to, because everything's kind of floppy and hypotonic, they're going to have a very weak suck, which is going to make this even worse. And then that jitteriness that they're getting from that low blood sugar. Nursing care, make sure the baby is wrapped up, kept warm, use of head covering, swaddling, skin to skin, delay the bath. In the NICU, you may see them, warming their IV fluids, before infusion. And it's highly recommended that they do not use formula at room temperature. It is warmed, and if you go into the NICU, you'll see them going through the warmers. So the metabolic system, again, a big shift in utero, especially your babies of gestational diabetic moms. They're used to this a large amount of glucose that's just circulating and bathing them day in and day out. So they have these large quantities of glycogen that are stored during pregnancy, and then they're born, and then these glucose stores, even if they're not born to gestational diabetic moms, can tank at about an hour post-birth. Moms trying to breastfeed, not very successful, things aren't working, babies struggling. So we know our normal adult hint 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 adult range is 70 to 100, right? Your neonates, I want you to think 40 and below. Okay, so 40 and below. 50 we're okay before you start treating. And think about if the baby has no other complications, what do we give someone if they're alert and oriented, no other complications, and they drop below 70? What is the first thing that you would do? Good. So I hope you said give them something to drink, give them a sweet drink of a quick acting sugar, right? Our key thing is like 4 ounces of orange juice. Same thing. Give the baby, put the baby to breast, have mom put the baby to breast, or give the baby a bottle. That is your first line of treatment. All right, so here is what's going on and how you're going to treat it. So you have your risk factors here on the left. Neonates of gestational diabetic moms are at high risk for hypoglycemia. Large babies, small babies, remember I told you large and small. Any neonatal infections, I forgot to tell you that as well, because what is the infection doing? The infection is taxing the system, and babies who have respiratory distress or who need neonatal resuscitation are at high risk for having hypoglycemia. So what do you see? You see jitteriness, low tone, flaccid, grunting respirations, irritable, lethargic, periods of apnea, and instability in maintaining their body temperature. So initially, have them feed, breast or formula, have them feed. They're feeding, you're giving them formula, they're not coming up, they're dropping, they're going to 30, or nothing's improving. Then they can start IV infusions of dextrose, and just trying to maintain that neutral temperature. Hepatic system, a couple things we're going to talk about here is iron storage, carbohydrate metabolism, which kind of talked a little bit about, and then with the conjunction of bilirubin. So as long as mom's iron has been adequate throughout pregnancy and they're checking that, and if she isn't, she's taking iron supplements. So as long as her iron has been adequate, the newborn is good up until about 5 months of age. And then when they start eating, they may need foods containing iron or supplements to prevent anemia. Again, the carbohydrate metabolism, the newborn glucose is about 15 milligrams per deciliter lower than maternal. We talked about that. So 40 is our range, remember? Working hard to breathe, loss of heat, having issues with respiratory distress, infections, babies born to mom who is GBS positive, didn't know it, had a precipitous labor, baby was born with, mom didn't get any of the antibiotics, those types of things. Next thing we're going to talk about is their bilirubin. So at birth, the newborn's liver must now begin to conjugate the bilirubin. So normally the baby will see a rise in their bilirubin for a couple of days. A term I want you to understand, highlight, revisit, go through is physiological jaundice. And this is caused by an accelerated destruction of the red blood cells. They have an impaired conjugation, and you'll see that increase in bilirubin reabsorption. So it's a normal biologic response of the newborn, that physiologic. So the peak bilirubin levels are reached about days 3 and 5 in your full term, and 5 to 7 in your preterm. And you want to assess for jaundice. You want to press on the skin. look in the yellow of the eyes, and it also has a caudal progression. So you'll see it in the upper part of the body first, face, eyes, mucous membranes, and then down to the trunk. All right, this gentleman does a nice job of going over neonatal jaundice, so I'm going to let you listen to this video.
Shortly after a baby is born, its skin may appear a bit yellow. This is known as jaundice.
Jaundice in newborn babies is really a normal finding. And the most common cause of jaundice in newborn baby is what we call physiological jaundice, which is just a process of adaptation that baby's making to life outside the womb.
Ryan is checking over Maria Vittorio's baby Tamami, who has low blood sugar levels. She's also a little jaundiced, although so far her jaundice levels are low and they don't need any further treatment.
When a baby's born, it's born with a lot of hemoglobin, which makes your blood red. And over the first few days of life, your hemoglobin level drops slowly, releasing hemoglobin, which then has to be metabolized. And a product of that is bilirubin, which makes your skin appear yellow.
I see.
For the vast majority of babies, jaundice is not dangerous and does not usually require any treatment. The jaundice first appears in the face and then creeps down the body. If you look very closely, you can tell a baby's jaundice by looking in the whites of the eyes. You can see that they're yellow.
Yeah.
And if you press the nose,
You mean in the white?
Yes.
Okay.
Babies typically do get some blood tests if they're detected to be jaundiced. We will look for evidence of conditions that might make the jaundice worse and therefore require treatment. Babies who present with jaundice in the first 24 hours and who are likely to become severely jaundiced, it's usually because of an incompatibility between the mother's blood group and the baby's blood group. For example, if the mother's a O group, she might develop anti-A antibodies to her baby if the baby has A group blood.
In extreme cases of jaundice, effective treatments are available to rectify the problem.
If a baby becomes significantly jaundiced, it will usually require phototherapy, which is a simple treatment where we lie the baby under a special light, which is at the extreme end of the blue light spectrum, which converts the yellow pigment in the skin to a different substance which can then be excreted in the baby's urine and therefore controlled.
All right. So decrease jaundice, maintain the body temperature. Again, we want to prevent cold stress. Key, big thing, highlight it, monitor that stool. That is how the bilirubin is getting eliminated. So you'll hear what's known as breastfeeding jaundice. And it's not caused by breastfeeding, but it's because the baby is not getting enough, because breastfeeding just hasn't been working well, so to speak. So it's results again in an inadequate stooling may result in reabsorption or recycling of that bilirubin. Encourage early breastfeeding, which actually serves as like a laxative. The colostrum helps to increase the excretion of the meconium and transition the stool. And again, like he said, some babies are treated with phototherapy either in or out of the hospital. And that's just an example of that Billy blanket that he was talking about. And this is what I was talking about for breastfeeding jaundice. It's associated with poor feeding practices, a lot of times inadequate fluid intake. So encourage frequent feedings every 2 to 3 hours. During the first week of life, bilirubin should not exceed 13 milligrams per deciliter. That is one thing I want you to know. It should not exceed 13 milligrams per deciliter during the first week of life. Coagulation. So a lot of what we see with newborns is their systems are still immature. So the baby has an immature ability for blood clotting. So one of the medications that an infant is getting is a vitamin K injection. Interestingly, a lot of parents, or should I say some parents, are starting to refuse the vitamin K because they think it's an immunization. They think it's a vaccine, and they don't believe in vaccines. And your role as the nurse is educating the parents that this is not a vaccine, because a vaccine, parents need to sign and give permission for, correct? So this is to help the baby clot, okay? So an injection of vitamin K is given prophylactically on the day of birth to combat any bleeding potentials. And then some of the things I want you to know is some parents will want to give that oral vitamin K. And although some hospitals just won't even give it because it's not even effective, because the babies don't have that normal flora in their gut to be able to activate that vitamin K orally through the GI tract. And they don't reach the full coagulation factors until about 9 months old. I'm going to have you read an article for our next lecture, and we'll go over it on administering intramuscular injections to a newborn. So I need you to know this. Vitamin K is given IM. The muscle that we use is the vastus lateralis. Some of you may have given IM injections already in the newborn mother baby. I encourage my students, if the babies need them, that they go in there and give these injections. It uses a 25 gauge 5/8 inch needle. So anybody who's been giving any IMs, you know a 5/8 inch needle is much smaller than what we're using on our adults. And it's anywhere from 0.5 to 1 milligrams, and that's given within 1 hour of birth. And it is not an immunization. It's not a vaccine. This is the steps. I used to have a video, but the video is now been pulled off of YouTube, and it was excellent. So I have to find a new one to show you how to give the administration of vitamin K. And if I find it, I'll post that under videos for you. So you want to clean the area thoroughly with alcohol. Use a 23 to 25 gauge 5/8 inch needle with the skin stretched flat between the thumb and index finger. You're going to insert the needle at a 90-degree angle to the long axis of the femur, so into your vastus lateralis muscle. Remove the needle. Some say massage the site, some say don't. So follow hospital policy, please. Okay. Again, oral vitamin K is not well absorbed. And again, we'll talk about, I have an article called Best Practices in Newborn Injections. I will be posting what I want you to do with that article in announcements. And that'll be in preparation for, I want to say, what April 6th and April 7th lecture. And there is a visual. So just take a look there. Here is your greater trochanter up in here, right there. Okay. There is your sciatic nerve, runs there, your patella. And then if you look, here is your vastus lateralis right in here, okay? I think I was talking about this in class when we talked about postpartum, because we were talking about the moms are concerned because they're not making enough milk, or they're only getting colostrum. But look at here, day one, look at the size of the baby's stomach as compared to 1 month, right? So putting that into perspective, it makes a lot more sense. Here, I want to say there's probably like 5 milliliters, if that, of milk versus almost 30 over here. Elimination, term newborns are going to pass their meconium about 8 to 24 hours of life. It is very thick, dark terry, and it's different from bottle fed to breastfed. Breastfed, it can vary. It can be 1 every 2 to 3 days. It can be many as 10 times a day, and the color can be yellow to green. So there is a breastfed infant stool. So you see the meconium, then you see that transition, which is green, and then that yellow in the breastfed stool. So there's a normal stooling pattern, again, in a breastfed infant. The kidneys. So I put here 93% of the infants void by 24 hours. Most of them void during or immediately after birth, but doesn't mean that their kidneys are not functioning if they don't void at delivery. 100% should be voiding within 48 hours. And usually about 2 days postnatally, you're looking at 6 to 8 wet diapers. Again, the immune system is very similar to ours. Even if mom doesn't want to breastfeed for long term, even if they're breastfeeding for just to get that colostrum, to get that immune system ramped up, and babies are given, this is a vaccine. This does need permission and from the parents. And the first one that they're given is the hepatitis B, and that is given at birth. That is also given IM. So I'm not going to go over that whole IM again, but that is also given IM. And they give one in the left and one in the right. Different facilities have different policies as far as which one is given in what leg. Okay. All right, let's go into the neonatal assessment. Everyone has this newborn assessment and flow sheet. Now, if you look, the flow sheet follows mom because it's looking at what type of delivery did she have? Did she have gestational? What is the gestational age? Did you know? So it's still looking at some of mom's assessment findings. Okay. So the baby's going to have 3 vital assessments, one immediately after birth. The second one is the nursery nurse is going to do the assessment as part of the normal routine admission. And then the third one, the nurse practitioner, the physician, the midwife will do one prior to discharge. I'm not going to play this video. Excellent, excellent video. I want you to pause and watch this video. Really good. It goes through.
We'll be reviewing the examination of the newborn. We do this exam.
So it's about 14 minutes long. It is amazing. It is excellent. It really covers everything. Does an amazing job. I keep that unless they get rid of that because I really like it. So just kind of quickly go through because the video goes through everything. What I want you to look at is after watching the video, you should be able to talk about the general appearance of the newborn, how to do the weight and measurements. We're going to go over all those skin characteristics and make sure you know those. A couple of other ones we're going to talk about is head caput succedaneum. It's a localized swelling of soft tissue on the scalp, and that is caused by the pressure of the head during labor, and it resolves 3 to 4 days. Go over pretty much the whole assessment there. So let's go over these terms, and there's a lot of them. So let's go through, and I just put here what I had in my notes. So just kind of go through it. So the first one we're going to talk about is vernix caseoso. Vernix caseo it's a whitish substance that you see on the baby's skin when they're first born. I'm going to jump around. So I'm going to go through some of the skin things first. Milia. Milia are tiny white papules. You'll see that on the face. And that is due to unopened sebaceous glands. And again, tell mom both vernix and milia are normal and they will disappear. The milia will disappear in a couple weeks. The vernix, the baby gets their first bath and we wash them. Okay. The next thing is Mongolian, let's jump down to the bottom, Mongolian spots. And that's macular areas of bluish, black, or gray pigmentation found on the dorsal area and buttocks of a newborn. Let's jump back up. You know what hypoglycemia is. You know what hypothermia is. Fontanelles, the babies have these soft openings at the cranial bones, and that is to allow overlapping to go through the birth canal. Lanugo. Lanugo is fine downy hair that you're going to see on the baby. The key is you're going to see on a preterm, you're going to see a lot of lanugo, and on a post-term, you're going to see very little lanugo, and we'll talk about that later. Circumcision is a surgical procedure where they are removing the surgical removal of the foreskin of the penis, and that is per parents' belief. Gestational age assessment is used to evaluate the normal newborn's physical characteristics and to determine gestational age, looking at the physical characteristics and the neuromuscular development. Cephalohematoma is a subcutaneous swelling containing blood found on the head of an infant several days after birth. We talked about the meconium, that is the newborn's first stool. It could be dark green or black. Or acrocyanosis, we talked about this when we did APGARs, remember? It's cyanosis of the extremities. Thermoregulation, we talked about the ability to maintain the body temperature, and Mongolian. Make sure you know your terms. Very important. You will see them again. The next set, again, I'll focus on the skin first. So the first one is erythema. Remember, erythema means pink or red. Toxicum, it's a pink popular rash with vesicles. It appears about 24 to 48 hours and it goes away in about 2 to 3 days. And just let the parents know that that's normal and that will resolve. Caput succedaneum is a swelling or edema occurring in or under the fetal scalp during labor. Let's go to Epstein's pearls. And your textbook, just to let you know, your textbook has great pictures of a lot of these. Epstein pearls is in the mouth. Highlight that. Epstein pearls is in the mouth. It's along the gum line. It's these little white blebs. And it's at the junction of the hard and soft palate, and is a normal finding. Molding. Molding is shaping of the fetal head by overlapping of the cranial bones. We talked about brown fat. Natal teeth. They are teeth and that are present it's very rare, but there are some newborns that have these natal teeth that are present at infant birth. Circumoral cyanosis. That circumoral means around the mouth. So it's a blue discoloration around the mouth. You'll see that in babies in respiratory distress syndrome. And then let's see, what did I not talk about? Cold stress, we already identified. It's excessive heat loss. Brown fat, we talked about in thermoregulation. It's those fat deposits that the babies have because they lack the that shivering mechanism. Meconium, meconium aspiration. That is the inhaling of the meconium. You'll see that sometimes when the rupture of membranes, and you'll see some meconium, the rupture of membranes. And we talked about circumoral cyanosis. If you need, take a break. I'm going to continue, but pause, take a break. This is where I would give you a break because I would think that you would need one at this point. All right, if you just took a break and you're joining me back again, I'm going to talk about the assessment of the baby's reflexes. And students love this. This is generally they do really well on any test questions talking about the reflexes. So the first one is tonic neck, and that is elicited when the newborn is supine, laying on their back, and their head is turned to one side, and then in response, the extremities of that same side straighten. So you see there the baby's head, the baby's supine, they're on their back, and they're looking to their left, and that left arm is straightened. And then the opposite side is going to flex. So if you look at that left leg is straightened and the right leg is flexed. And that persists to about 3 months. Grasping. They're like, oh, they're holding my hand. It's so cute. So grasping is elicited by you stimulate the newborn's palm with a finger or an object, and they reflexively just grab that finger. Moro is that startled response. They get scared. You can do that by clapping really loud. lifting or lifted slightly above the crib and then like kind of suddenly lowered. Of course, you're holding them. Their arms will extend, their knees will flex. Their fingers will kind of form a C, and that'll persist to about 6 months of age. Rooting is where you touch the side of their lips, and they kind of go over to that to try to suck on, that'd be, if you use like your gloved finger, and they would go over and try to suck on that gloved finger. And then sucking is taking that one step further and taking that gloved finger and putting it in the newborn's mouth. And they check this to see if they have a sucking reflex, which obviously they need to eat. Trunk incurvation, also known as the gallant reflex. And here the baby is on their prone position, and then you strike the spine with your finger, and it causes the pelvis to turn to that stimulated side. So in this, the baby, they're doing a curved striking of the spine to the left, and then you see that they curve over to the left side because that's the side they're being striked. And if they did that to the right, then you would see the right leg and arm go up in response. Babinski in newborns is normal. After you had Professor Terry in neuro, that is abnormal in adults, right? So that is elicited up to 1 year. And what you do is you take your finger and you stroke the outer edge of the sole of the foot, moving up towards the toes, and then the toes will fan out, as you see in image B. Stepping. They're like, oh, my baby's already learning how to walk. It's so cute. This is up to about 4 weeks, and you hold the baby over top of a flat surface, and the baby kind of like tries to walk across the table, so to speak. All right, that was our reflexes. Next thing we're going to talk about is maintaining a clear airway. So when the baby's born, you need to have everything ready. You want to be prepared. Always, always be prepared, whether you're in newborn, nursery, labor and delivery, med surg, whatever. You want to have everything you need there. There's nothing worse than needing and not having it. You'd rather have it and not need it than need it and not have it, right? So make sure everything is readily available. Your O2 is there. You want to be taking the baby's temperature. It should be between 97.5 and 99. They're going to have their vitals taken every 30 minutes until stable for 2 hours. Respirations, normal newborn respirations are 30 to 60 respirations per minute. They may be irregular, and that's okay. Tell mom they may have some brief periods of apnea. As long as there's no color change and everything else is normal, that is normal. They having brief periods of apnea lasting greater than 10 seconds and other signs of distress, that's a concern. Pulse is between 110 and 160, and you don't do the blood pressure in the postpartum unit. But if they were in the NICU and they were measuring their blood pressure, it should be between 60 and 80 systolically and 40 to 50 diastolically. I'm not going to really ask you as much about their blood pressure, but I do expect you to know a normal temperature range, which is 97.5 to 99. A normal respirations, 30 to 60, and a normal pulse, 110 to 160. Maintaining that normal, neutral thermal environment. I think we talked about that pretty much already, keeping that baby warm. So I won't go. But one thing I do want to mention, and this isn't just for newborns, I hope when you guys do vital signs, I always warm my stethoscope up, whether I'm taking care of newborns, toddlers, kids, adults. I always warm that up before I go and put my stethoscope on someone. Another medication. So far we've talked about 2 newborn medications. The first one was that vitamin K, which is an IM injection given in the vastus lateralis. The second one we talked about was the first vaccine, hepatitis B, given IM as well. And then the next thing we're going to be giving is erythromycin eye ointment. And that is legally required for the prevention of gonorrhea. It is given, and you don't need to give that immediately. You can wait a little while so that parents have a time to bond. Not real long, but the reason is because it can cause blurred vision on the baby, the swelling of the eyelids and stuff like that. It can be irritating. Picture me opening up your eyes and putting, a medication in your eyes that's has like a um, petroleum jelly base, not necessarily, but just picture that kind of. So you can wait a little while to allow that bonding. Maintaining skin integrity. So you want to keep that baby clean, um, and keep the skin clean, dry, and intact. Look at that umbilical cord, assess for any signs of infection. If they had a circumcision, you want to monitor, for any signs of infection. So, you want to leave that umbilical cord open to air. If you do need to clean it, it's just sterile water, nothing else. Fold the diaper down to prevent any coverage of the stump so it can get to air, and monitor for signs of infection. Teach the parents what to let you know, any foul smelling odor, any green, yellow drainage, local warmth, temperature, red, and if it's not healing. Promotion of safety, a big one is, and we talked about this in postpartum, so it's just a refresher here, is security. The baby has the hugs. Different places have different policies. Only allowing someone into the birthing unit that has identification. That's why it's so important when you do go to clinical that you do have your identification on you. Never leave an infant alone. If mom looks especially tired, offer to take the baby back to the newborn nursery and let her rest. Prevent infection, hand washing, hand washing, hand washing. I don't think we can stress that enough. Circumcision is basically the surgical procedure where they are removing the epithelial layer covering the tip of the penis. Analgesics are used during the circumcision. They actually will use oral glucose. I'm not sure if you read about that or seen that being used. They'll use that to help with pain, and a variety of devices are used. I'm not going to expect you to be able to tell me which one is used, but what I want you to know is it's really important because there's a lot of swelling afterwards, and we're watching for signs of infection and hemorrhage to make sure you're documenting and observing for that first void, because if there's a lot of swelling, they may not be able to avoid, and that can be a problem. We have to go back and look. So petroleum and gauze are applied to the site to prevent and bleeding, and also we obviously don't want to debride that area when we're changing the gauze, so thus the petroleum impregnated gauze. Newborn screenings, I think we kind of talked about the immunizations. I don't get into the immunization schedule, so for me, do not be memorizing the immunization schedule. I do not get into that. That is for pediatrics. The screening that I want you to know that every newborn needs before they leave the hospital is hearing. That is conducted in all 50 states. Vision is not confirmed until after they're home. So they're having that done within a month. That is not something that is done in the hospital because their vision is blurry. They've had medication put in their eyes and different reasons. So that is something that is done outside of the hospital unless they're in the NICU for a long time. And then I have here under other screenings, they're doing a whole host of blood tests, cystic fibrosis, PKU, hemoglobinopathies, pronounce that quick, maple syrup urine disease, different things like that. And then the immunization that they're getting is hepatitis B. Remember, vitamin K is not an immunization, although many parents will insist that it is. That is the end of the lecture. If you have any questions, please feel free to post it. The best place to post it is in the Q&A, so that if you have a question, probably one of your other colleagues in your class have the similar question. versus sending an individual email where only the student who's sending the individual email is learning from from that question. And certainly you can, in your notes, put it down there and we can start lecture of any, reviewing any questions from today's content. Thank you and have a good day.